Thank you, Leslie. So twice. And thank you, Carlo, and everyone for the invitation. It's my pleasure to be here with you. I'm on this side so I can see, because short people cannot see the slides. So it's my pleasure to be here and tell you why we created an Advanced Breast Cancer Global Alliance. Why was it important, and how the idea was born and how it has evolved. It's been quite a number of years now, and I'll try to explain the history. I'll take the opportunity to explain some basic principles. I know that some of you are very familiar with what I am going to say, but maybe others is the first time they hear. So I'll start simple, and I promise I will not complicate too much. So I'm going to start with some numbers, because I think it is important that people realize that what we are talking about is not just a handful of people. Oh, I forgot to do something that Carlo asked me. Welcome to everybody online. So it's not just a handful of people. This map is the burden of cancer around the world. And the way you can read it is by color. Where you see blue, either dark blue or light blue, cancer is either the first or the second cause of death. And only in the in the poorer countries is where cancer is not yet the first or second, but it's already third or fourth cause of death. And what we know is about 70% of cancer deaths occur in those what we call low middle income countries. And this is very important, because we are going to speak a lot about research, new treatments, but actually that only is able to help a tiny percentage of the breast cancer patients that exist in the world. And that's also one of the reasons we created the Alliance. Now, when we see the same map, but just for women, you see that there is a lot of pink, because breast cancer, and here is in terms of incidence, so number of cases, and you see that breast cancer is the top cancer for females almost everywhere, except in some of the poorest countries where cervical cancer is still the first cancer. And this is changing, because now we can prevent cervical cancer. And so a lot of countries have started the prevention techniques. Now, when we look at mortality, you have a little bit more mix of colors, because fortunately, although breast cancer is the one that affects the highest number of people, it is not the one with the highest mortality. For example, lung cancer that you see in blue, it affects also a good number of females, not as much as breast cancer, but it kills more. And so that's why for mortality in certain countries, lung cancer is more, it's the first one, and breast cancer the second. Now, I went to check all this data. You can have it freely online on a website called GlobalCan. And you can go there and find things specifically for the UK or specifically for Europe. For me, you're still in Europe, although you always say that you are something between the US and Europe. No political things here. I just consider the UK in Europe geographically. And what will happen in the next years, as you can see here, is not going to slow down, right? So the incidence is going to continue to increase, and so will mortality, because in terms of numbers of people that are affected, this will continue to increase. And to put the numbers into something that it's easier to see than curves, so here's the number of new cases of breast cancer per year around the world, 2.3 million in 2022. In 2045, it will be 2.36 million. So this will continue to rise unless we find a way to also to prevent breast cancer. Now, I said I will start in the basics, so let me start with just explaining to you what cancer is. I found throughout the years that the basic understanding of what is a cancer cell will help you understand a lot of things. Even, for example, the side effects of the treatments that we use. Why is this important? Because, you know, for many diseases, especially the infectious diseases, the disease is caused by something outside your body. You know, a virus, COVID, now everybody knows what is a virus, but also bacteria, all sorts of microorganisms that go into your body and give you a disease. Cancer is different. It's something that starts in your own cells. So it's your own cell that, for different mechanisms, became a little bit crazy. So it gained some capacities and lost some other capacities. So a normal cell, the cell gets born, it grows, but also develops a skill. Like you have the cells of the skin have a different skill than the cells in your brain. But they have a skill, they have a function. And after a certain moment in time, they die. That's the natural history of a cell in our body. Well, cancer cells have lost the capacity to die. And they have become immortal because of that. And they have also lost this capacity of having a function. So they are not having any function, and so they use all their energy to grow. That's where they put all their energy, is to grow. And the third characteristic that they gain is they are capable of hide themselves from our immune system. So if we have an infection, our immune system knows that that thing, that virus or bacteria, is something strange to your body and needs to be killed. But they do not recognize cancer cells as something strange to your body because they are your own cells, and so they don't know they have to kill it, okay? That's what makes cancer cells sometimes so difficult to kill without hurting the normal cells. So this is just a summary of what I just said, and I think this simple cartoon is, I hope, help you to understand why cancer develops and how we have to think when we want to develop a treatment to kill these cells. Now, okay, we understood what cancer cells are. Now, why do we have metastatic cancers? So these green cells are supposed to be the cancer cells. There's another characteristic that they gain. They gain the capacity to go into the bloodstream or the lymphatic stream. They go into the vessels and they go and walk around your body. And then also, for reasons we still don't fully understand, each of them find some attraction for other organs. Some of them prefer the liver, others prefer the lungs, others prefer the brain. And so they leave the bloodstream or the lymphatic stream and go to those organs and start again growing. And that's what we call metastases, which are like little babies of the primary tumor. This is putting it very beautifully when they are not beautiful. But just so you understand what I'm trying to explain, without the beauty of it. Now, when we always talk about breast cancer, but breast cancer is not just one disease. And there are several ways we can classify breast cancer, and I'll start with the easiest way. The easiest way is to say there are three main types of breast cancer. One that is the most frequent of all is the one that we call hormonal dependent. Okay? It's about 65–70% of the cases, and it's one that has these receptors that are little antennas in the cells called hormonal receptors, estrogen receptor, progesterone receptor. And this is what feeds the cell and makes it grow. then there is a group of about 15–20% that have a different type of receptor called HER2. I tried to simplify the name HER2. There is no way to simplify. That's the simplest that we can do. But suffice to say that this is what feeds this type of breast cancer. And then when you don't have estrogen receptor, progesterone receptor, and HER2, so you don't have these three things, then the cancer cell is called triple negative. Okay? Now our work is to define something positive about the different types of the triple negative. Now this is the simplest way. Then it gets a little bit more complicated, because when the pathologist looks into the microscope, sometimes the cells don't look exactly the same. The vast majority of cancer cells, they start in the ducts. So our breasts, they have small ducts where breast milk is produced when a woman is pregnant. Those small ducts that all open in the nipple, this is where the most common cancers occur, about 85–90% of cancers. But there are other cells that can also become crazy and malignant, and then we have a different classification. Don't worry, I'm not going to go further details than that. And then since the 2000s, in the beginning of 2000s, you all heard that we were able to decode the human genome. After that, we started to decode the tumor genome. And today we have atlas of all the genomes of all cancers that exist. And one of the first ones was breast cancer. And this is just a figure that I'm sure everybody has seen. These are genes. Green and red, never understood why they chose exactly the colors that people who have colorblind cannot see. But here you go, they chose green and red. And these are genes that are activated or others that are inactivated. And what we found is that really it proved what we already knew in the clinic, that we have 3 main types, perhaps 4 main types of breast cancer, because the one that is hormonal dependent, we can split in 2, one that grows very slowly and another one that grows very fast. Now, we also learned many, many years ago, this is a very old slide that I borrowed from one of my mentors, Martin Picard, just to say that we can classify all cancers by stage. And stage 1, 2, and 3 depends on the size of the tumor, the number of nodes. They are potentially curable. And then stage 4 is when there are diseases, the disease is outside the breast and the lymph nodes. For the moment, most of the cases is incurable, but there is a change in mentality, and that will be my last slide about the change in mentality for metastatic disease. You can also, Leslie told you, you can also be diagnosed with metastatic disease already. This is what we call de novo metastatic disease, that in high-income countries, countries that have a screening program, is usually around 10–15%. But in low-middle-income countries, it can be up until 80%. Okay? Now, I'm sorry about the photos, but I really want to explain to you why, for the Alliance, we use the term advanced breast cancer. We wanted to include 2 situations. One is the traditional metastatic, so lesions outside the breast and the lymph nodes, that you in the UK call secondary, which we don't like very much because scientifically is not correct. It's not always secondary, it can be primary, right? So we can talk about it later, how we can go about that. But there's also a group of patients that have very locally advanced, very inoperable. It's not possible to treat them with surgery. And they are lost between metastatic and early breast cancer. And we wanted to include both of them in the fight of the Alliance. And that's why we use the term advanced, to include locally advanced and metastatic. Now, many years ago, I had less gray hair, I looked into the curves of early breast cancer, and these are the curves. You see that UK and US, but it's the same for the majority of high-income countries. You see there from the 90s, there is a very important drop in the mortality. When we look like this into studies in population, we have to think what happened 10 years before. What happened 10, 15 years before that has led to this? So what happened in the field of breast cancer around end of the 70s, beginning of the 80s? A couple of things. So this is where people started the screening programs. And I'm not going to focus on that exclusively. I'm just going to say early detection, because advocacy, awareness, this is also very important, even for ages that do not do screening. But let's say screening and early diagnosis, this was started in the majority of countries, US and Europe, around late 70s and 80s. And also, at that time, was when the first chemotherapy was developed and the first hormonal therapy called tamoxifen was developed. And so you see what altogether can lead to that drop in mortality. But when I was looking into these curves, I also saw the curves for metastatic disease. And here, you cannot see the different curves over here, right? They are all overlapping. And this is from the years 2008 to 2013, but could be even bigger. For a long, long time, the survival was stopped in between 2.5, 3 years. And there was not that drop. So I started to look at that and say, why? Why is this happening? And if we look again into this difference between de novo and recurrent, you have a little bit better survival with de novo than you have with recurrent, because de novo has never been treated. And so there is less resistance. I'll come back to this later. But still very, very small number of years. So I thought, okay, what can we take from early breast cancer and apply to metastatic breast cancer to make the difference? And it came to my mind that there are two very important things: treating according to guidelines and within a dedicated, specialized, multidisciplinary team. You have to understand that in the beginning of the 2000s, when we started this effort, there was almost no guidelines to treat metastatic breast cancer, because people will say like that, oh, it's incurable, so I can do whatever I feel like it. Believe me, that was the feeling among the scientific community. And they said, oh, this metastatic, it's only for the medical oncologists. The surgeons don't need to be involved, or the radiation oncologists, or any other specialty. And we wanted to change that. And when you see a big, big, big problem, at least that's what I usually do. I try to cut it in smaller pieces and tackle one by one. Otherwise, you get discouraged with the size of the problem. So the main focus of the Alliance was to always fight that every single metastatic breast cancer patient has to be treated evidence-based with the best available treatment according to the guidelines and by a team of specialized interdisciplinary, not just even physicians alone. I'm looking at Leslie because she's verifying what I'm saying. So there are some main principles of modern oncology that we started to apply in early breast cancer, and we start fighting for it to be applied also in metastatic. Multidisciplinary, I told you. Specialized breast cancer units. Evidence-based. Individualized therapy. I have to tell you that we talk about this for maybe 2 decades. We're still not there, but we are coming closer to have a more targeted, individualized treatment, and always respecting patient preference. And you know, I put this here because you are patients, but some of the advocates that go into conferences, I think You must have heard about patient preference and patient-centric medicine over and over again, but then they don't listen to you, actually. You're just sitting there because it's nice to have a patient or a patient advocate, but you're not listened to. And this is really what we want, is to listen to you, what matters to you, right? And we are starting also on de-escalation. It's probably not the best word, but to optimize the treatment, not going too aggressively when this is not going to solve the problem. So that's how everything started, and I summarized in one slide almost 15 years of work. So we started with a working group to create some guidelines, and it was really just recommendations. 12 recommendations was the first manuscript. And then we dissected each of them, and it grew, the work grew, and a lot of people became very interested, so much so that we had to create the first conference dedicated to advanced breast cancer. And that was ABC1 that took place in 2011, so many years ago. I was already with Leslie. I'm sorry, I don't want to make any confusion, but Dame Leslie. And so over the years, the interest became more and more, and a lot of people wanted to be involved. And the last one took place 2 years ago. It takes place every 2 years. And you see that the panel for the consensus is increasing. Every year is increasing. And we produce a manuscript with algorithms, with statements. But what is different about these guidelines? Because fortunately now you have different sets of guidelines. You have guidelines from different societies, national and international, but at the time when we started, there were no such thing. But the difference of these guidelines is that patients are in the panel, in the consensus panel. And so they have the same vote as me, have the same vote as any physician or scientist, because this has to be done with you, for you. And that was always the goal of the Alliance and the consensus guidelines. We also wanted to have a global perspective and to be practical. You know, not to say, okay, there is this list of treatments that are available, now you choose. No, help you to choose. How do you choose among all the options? And what we do also is we take these guidelines and we adapt it to the different countries with something we call Best of ABC. I just put here 2 examples. One that we do in Latin America every time with all the countries in Latin America, and the other one that is started to be done in New Zealand because they didn't have any guidelines for metastatic disease. And what do these guidelines say? I'll give you 2 or 3 examples. So, what are the goals of treatment? Let's understand the goals of treatment in the metastatic setting. We want to improve the length of life, which is survival. Obviously, we want to do that. But if that is not possible, not every treatment achieves that, at least we want to delay progression, we want to control the symptoms, and we want either to maintain a good quality of life or to improve the quality of life if that's not a good, if the patient doesn't have a good quality of life. And perhaps in the near future, we're going to be able to transform these, at least 2 of the subtypes, into a more chronic disease. Now, this balance that I put there, quantity and quality of life, is a very personal thing, right? If I would ask each of you, you probably give me different answers. How much of toxicity would you be able to endure for 2 more months of life? Everyone would say different things, right? So that's why a decision has to be different for each patient as well. So if our goal is to treat for as long as possible with a good quality of life, there are a couple of things different in the metastatic setting. We have to focus on the side effects. Maybe for some of you, losing the hair is the most important thing you want to avoid. For others, maybe to have neuropathy, to have the tingling or the loss of feeling in your hands and your toes. Depends on what you do for a living. I always give the example of a surgeon. Certainly, a surgeon doesn't want to have neuropathy, right? And we use too high doses. We don't need to use so much high doses, and we should not be afraid to reduce the doses. Even sometimes you are afraid to reduce the dose because you think, if I reduce the dose, I'm not going to have the same benefit. It's not exactly like that because we use too high doses anyway. And if we can develop oral treatments, it's much more convenient. You don't have to go to the hospital all the time, stay there for the IV treatments, and you can hopefully keep your work, if they let you, keep your work and continue to do what you like. And again, the patient preferences. So there's also this wish to tailor the treatment to the individual. And to do that, we have to use what we call biomarkers. These are biological factors that help us to understand what treatment would be best for that specific tumor. Okay? But there are many other factors, and we fight in the education provided by the Alliance to make the physicians understand that there are many other factors besides the tumor to consider. And so to simplify this slide, we can put there are patient characteristics, tumor characteristics, which are the biomarkers, and also disease characteristics. And all of these should be taken into account for that balance. But this is an example of an algorithm that the Alliance does. It lists the biomarkers that exist and that should be asked for a breast cancer patient. And I'm not going to read that. That's not my role here today. But it just emphasizes two messages. One of the things you have to be extremely, extremely careful is to have a high-quality analysis of the tumor. If the pathology analysis of the tumor is wrong, the treatment that we will give will be wrong as well. So one of the things we have to fight all over the world is to have high-quality pathology. And then biomarkers are expensive. We don't need to ask all of them, especially if we don't have access to the treatment that needs that biomarker, right? And the other thing we have done was I've learned this with Leslie Fallowfield, bang the heads of the physicians until they understand what it means to integrate the patient perspective in cancer care. It takes time for physicians to understand, sometimes also nurses, but physicians are more stubborn, to learn how to integrate. So if I'm defining priorities, it's not my priority, it's the priority of the patient. If I say acceptable toxicity, it's not acceptable to me, it has to be acceptable for those who are receiving the treatment. And if I say, oh, this is a great treatment, it has a substantial benefit. What is a substantial benefit? How do you define a meaningful benefit? You have to do that together, right? And not alone. So that has led to the creation of the Alliance. The Alliance is like a federation. The members are organizations, not individuals. And we are almost 300 members all over the world. And the two words that define what we do is collaboration and sharing. Because you don't have to start from zero. There are so many things that exist already, and you just need to share, and then you will speed up the progress in all the countries, hopefully. I'm going to skip this because I already explained, and tell you that one of the first things we have done, about a decade ago, was all together, all the involved stakeholders together, defined the goals for metastatic breast cancer. And we defined 10 goals for the decade that is almost ending now, from 2015 to 2025. And you will see that these goals, and you can find a copy of this charter in the booth outside, But one has to do with survival, the other with quality of life, the other with data. Carlo already mentioned, we don't know how many patients are living with metastatic disease. The other one with accessibility to everything we need, multidisciplinary care, fighting against stigma that still exists today, and the right to continue to work if you wish to do so. So all different priorities, but they were defined as the most important ones. And what I would like to tell you is that this year in November, the decade is coming to an end. So we have prepared a report of what happened in this last decade around the world for each of these 10 goals. And we will be launching that at ABC 8. And that is the work that is the fundament to create the next 10 goals for the next decade. Okay? So I hope many of you, some of you, will be able to attend the conference in November. I'm not able to tell you today the results of the report, but I'll briefly mention for 2 or 3 goals what we have seen. So what we have seen, I showed you that for a long, long time, median survival was stuck at 2.5 years, 3 years. Now we have, for 2 of the subtypes, we have a median survival of 5-6 years. So when I say something like that, how many of you understand what I'm saying? What is a median survival? Yeah, but it means that 50% of people live longer than that, and 50% live less than that, okay? So it means that there are 50% of people that are capable to live, for example, 10 years, 15 years, right? With metastatic disease, something that we were not used to see. But now for HER2 positive and hormonal dependent cancer, we are seeing that. Now, that is if you have access to all the treatments, right? And all of them are quite expensive. Now, because I don't have time to go into all the details, I'm going to speed up a little bit. I apologize. But then I get carried away and I take a long time to speak. So there are main problems in oncology is the selection of patients. I told you about biomarkers before. And this thing called tumor resistance, okay? What is that? So this is a cartoon that tries to explain to you. So we start there from your left. The tumor is not the same, right? They are different cells. And you give a treatment that, according to clinical trials, is the best one. Usually you have a response. The tumor becomes smaller. But then the tumor gets used to the treatment that you are receiving. It develops resistance and regrows. And when it regrows more aggressive with more mutations and more heterogeneous. What can we do? Well, we have to give a different treatment, right? And hopefully there will be a response again. And that's why a lot of patients refer to this natural history of metastatic disease as a roller coaster, right? You're well, and then you're not well, and then you're well again, and then you're not well again. What does this tell us? It tells us that we need to go and biopsy the metastases and find out what has changed in the tumor. It also tells us that we need several treatments available. And some of the payers in many countries say, I'm not going to approve this drug because you already have that one. And we have to speak to them and say, that's not enough. I want to live 15 years. I need several treatments available so that I can take them in a sequential manner. And so that's one way we can overcome resistance is developing smart treatments. Maybe the paradigm of that is the anti-HER2 treatments, where we develop quite a lot of efficacious and well-tolerated treatments. All of them are terribly expensive. And now for even the triple negative, we also have these smart therapies, Over there you see immunotherapy. I'm happy to explain that on whoever wants to ask. PARP inhibitors, and this here is a class of agents that change the hormonal dependent cancer, so the CDK4/6 inhibitors. But we can even do smart chemotherapy agents that have the same efficacy with less toxicity. Again, all of them are very expensive. And that leads me to one of the other points of the report, where you will see, this is an old graphic, but it shows the countries of Europe lumped together in different clusters. The ones you see there in red are all the Eastern European countries. And you'll see that the inequalities this decade have increased, they have not decreased. And they have become important not just between countries, but within each country. And I think you know, because one of the examples is always given is the postal code problem in the UK. And so people in the same country have different access, right? And it doesn't matter if I develop a wonderful drug and then it's not accessible for the majority of patients. And this is another way of showing this. In high-income countries, 9 out of 10 breast cancer patients is able to survive. Where you go to Africa, is 4 out of 10. Okay. So it's not just the expensive medicines, pathology I explained to you. Radiation is very different all over the countries and within each country as well. And what we are now fighting is that even the least expensive drugs like tamoxifen, we don't have, because they don't give a profit, so they are not produced. And for example, in Portugal, I was out of tamoxifen for half of the year, last year and the year before. So it's a big problem. And the last thing I want to say is about palliative care and pain control. So this is a different type of map. And you see that some countries are inflated because they overuse the opioids. And in other countries, they almost don't exist. And people die in pain, right? And this cannot happen, not in 2025. So because I went on and spoke too much, I don't have the time to go until the end of my talk. Should I continue? I don't want to go over the, okay. And I don't want them to fall asleep after lunch. Okay. So just a brief explanation on why we don't know how many of you exist in the UK, for example, or how many patients exist with metastatic disease. And this is because the cancer registers, they register diagnosis, so we have incidence. They register death, we have mortality, but they don't register relapse. And so all we know is something that they call prevalence. What is prevalence? Is someone who had a diagnosis of breast cancer within the last 5 years and is still alive. So that means it's all the survivors plus all the metastatic patients. But how much is one and the other? We do not know. So this is a long, long fight to change the way registers, cancer registers collect data. And I'm really going to finish after this next topic. I don't have the time to go, but I will give you my slides. And the last part of the talk is more on the resources that you can find within the Alliance, and it's very easy to go through, and you can go through my slides, okay? But all of this started in the beginning of the 2000s. I saw 2 surveys. One was called the Bridge Survey, and the other one was called Silent Voices. One led by a patient advocate, Silent Voices, and the other one led by pharma. And you will see that many of these efforts were either run by pharma or patient organizations. None of them was led by a physician, incredibly. And those 2 surveys show that all the patients with metastatic disease felt abandoned. Abandoned by the physicians, by the researchers, even by the patient groups, by the decision makers, and they were not. They felt that they were not understood, and so that what motivated me to create the alliance. And this effort or survey has been repeated, some globally, others more nationally. And what is the conclusion of all these efforts? So, and this has been repeated 10 years after. So, at lower percentage, but patients are still having problems accessing information. And the information now exists. So how come they are not accessing? It's a issue we are dealing with in the report. They still find difficult to have support for their families and carers. They still feel that the general public doesn't understand the difference between early breast cancer, the pink movement, and the reality of metastatic. And when I speak about stigma, it's not just the general public. There is stigma within the community, the physicians, and even some patient groups as well. And they need better communication with their healthcare professional team. And what has gone a little bit worse than in the beginning of this effort? Accessibility, because a lot of things are much more expensive today. Financial support. Sometimes there are financial support services, but patients are totally unaware that they exist in the area where they live. Employment support is something we didn't have time to discuss, but I believe we will discuss in some other session. And also it has become so complicated that need to help navigate all the services and all the available treatments. And I mentioned already the problem of not knowing. And then I still see, I travel around the world and go a lot to low middle income countries, and I still see the same comment saying, I can do anything I want because it's incurable. It's not true. There are guidelines, and there are the best, and also the second best if you don't have access to the first best. And so I'll finish up with this. I know last year, Carlo, you passed the video, so I didn't put the video in the presentation, but we have done some awareness campaigns, but for me the first one was the most impactful one, and I invite you all to go to the website. It's just 1.5 minutes, but I'm sure that you will find very compelling about the work. So I'll stop here and take any questions.
So I'm Marina Part. I'm one of the breast medical oncologists working with Carlo, Leslie, and Make Seconds Count. So thank you so much. That was fabulous, absolutely fabulous, and I think has really laid the landscape for this conference. Now, we have a few moments for questions. So we have roving microphones if you want to ask questions from the floor, and you have Slido. So on your table or at home, there's a QR code. You can download this if you don't want to put your hand up and ask questions. You've left them stunned, Fatima. So.
Sorry.
So I'm going to just ask from a physician's perspective, actually. During the time that you've been doing the ABC guidelines, have you seen a shift? I pray that you have, but yes. Have you seen a shift?
Yes, in fact, I've seen two major changes. The first one I saw was on patient advocacy groups. They were the first ones to change. When we started, most of the patient advocacy groups didn't have resources for metastatic patients. Mm-hmm. And now when you go to almost all of them, international or national, they are careful to have resources dedicated to metastatic. So there was a change there. And in terms of the physicians, I think now There's still obviously exceptions, but I think now that everybody understands that evidence-based is the way to go for everybody. It doesn't matter if the disease is curable or incurable. And so that is a change. Now, I said that there is today a plea to a change in mentality, because we have to focus. I don't know if you're going to understand what I'm going to say, but in the beginning, we have to focus on the differences between metastatic and early and explain why it was different. And one of the reasons is the fact that it's mostly incurable. So you have different types of needs. But now we are seeing the light at the end of the tunnel and thinking that some cases, maybe they can be cured, and at least some can, you can live with it for many, many years. To be a chronic disease, you have to live decades with something, not just a couple of years. But there is light at the end of the tunnel, and we want to have a realistic but a change in mentality, because there's also a lot of stigma within the healthcare professionals. And for example, just an example that happened during the COVID pandemic, if you would have cancer, but especially if you had metastatic cancer, you would go to the bottom of the line in terms of access to ventilators. That happened in many, many countries. And this is the stigma within the healthcare professionals that we want to change. I still need to fight with, I'm sure you too, with my colleagues from intensive care when I say this patient needs to go to intensive care because, for example, she has a side effect of immunotherapy. And they say, oh, no, it's incurable. I don't want her in the intensive care unit. So this, we still have to fight, but there is a change in mentality.
And thank you for highlighting that, because I think that's a very real but difficult to discuss issue. So we have a question for there.
Hello, Fatima. Thanks very much for that. It was really interesting. A question I wanted to ask you is about the data collection. So we saw a lot of posters there that went back almost sort of 10 years around how often we've been asking for this to be collected. Are the challenges just in breast cancer, or is that cancer as a whole, and what are those challenges?
So thank you. It's a challenge for all metastatic cancers. We don't know. We don't know how many metastatic lung, metastatic colorectal. We don't know for any. The challenge is so the way cancer registers were developed was many, many decades ago, when once there was a relapse, death was very close. And so they didn't think it was important to count the relapse and then death because they were very close. But now it's not the case for many cancers. And after a relapse, you can live for many years. So now they have to reorganize themselves. But people change, right? You may be treated for early breast cancer in Liverpool, and then you go live in Lisbon afterwards, and you have your relapse in Lisbon. So how can we speak all the cancer registries so that we can track the patients? And then all these data protection laws made it impossible for us to track the patients. I don't know how, people want to sell things, always get my phone, but I am not able to track you if I want to track you. But what we are fighting is to have the patient say, I don't mind being tracked by the cancer registry. And for example, if someone has a cancer, uses chemotherapy, goes many years without using, and then uses again, this should be a red flag to the cancer registry and say something happened, either another cancer or a relapse, right? That would be a good way to track people, but it's very, very complex. But we will not shut up, and we will show at ABC8 that there are efforts. There is one in the UK, I'm sure we will talk, but there's recently published in Australia where they were able to count in one of the regions, and they found out that they found that the number was about 3 times more than that was estimated. So what we believe is that there are many more metastatic breast cancer patients than the models we have estimate.
Leslie. Oh, should we just take two questions, one at the back there, and Leslie here, and then we might have to bring it to a close. I'm sorry about that.
Hello, thank you very much for that informative talk, Dr. Cardoso. My
everyone can call me Fatima, I don't
Fatima. My observation, and it's not isolated to here, anytime you get statistics, so we see on the news early breast cancer, survival rates going up, even with your figures when they were giving the median life expectancy, triple negative is never included in the statistics. So when you're talking about stigma, there's a stigma even within our community for triple negative, because it's almost as if you include that, it shows up some sort of failure, or, well, these set of people it doesn't apply to. So how do we get away from that? Because the minute you mention triple negative, it's like, oh my gosh. And if you, this is not a criticism, but if there were figures up there that at least gave me an idea of where we are, because when you look on the internet, it's the worst. And I said to someone, I've never actually looked at the life expectancy, because my oncologist said to me, you will see figures that are out of date because we've got nothing new, and it will be the worst case scenario you could imagine. But there doesn't seem to be any change in that, because X amount of years down the road, and I'm not seeing anything that says to me, this is where we are now. And as I said, it just gets left out. ER positive, all the rest, nothing about triple negative. How is that going to change?
Well, it is changing, and later this year when we present the report, you will see, and I had many more slides that I didn't have time to go through, and I had the survival per subtype, okay? And it's true that the worst survival on average is the triple negative, but that also is changing. And what is also changing, because we now have targeted therapies as well, like immunotherapy. It's not for everybody, but it does increase the length of life. But what is also changing is that we are finding out that there are different types of triple negative, and that we can maybe develop treatments specifically for these subtypes within triple negative. And there will be some that have better prognosis than others, unfortunately. But when I speak about, on average, that the survival has increased, is including the triple negative. If I wanted to tell you the median survival without the triple negative, it would probably be above 5 years, okay? But altogether, the three subtypes together is around 5 years. When we started 10 years ago, it was about 2.5, 3 years. So it was an improvement. Not enough. I know very well if any of us is said you have about 5 years to live, we don't find that enough, right? But it's still better than it was 10 years ago. Our expectation, and what we will put in the charter for the next decade, is that we double again. And so that in 10 years' time, probably not going to be me because I won't be able to climb the stairs, but in 10 years' time, I hope that we are talking about over 10 years, the median survival. And again, median means that 50% would live longer than that, including triple negative.
Leslie.
Hi, thanks, Fatima. I thought that was a great talk, very thought-provoking. And I have heard a few people talking about the possibility of some exceptional groups of patients being cured, which is a word that I'd never heard used before for metastatic disease. And it's very exciting, but how realistic is that? And one thing I just wanted to say to everybody in the room is I attended the Global Alliance conference, I think 6 years ago, and it was fantastic, and they offer patient travel grants. You might be too late for this year. I've applied, so fingers crossed I get a place, but it's really, really worth going to. And there's a great bunch of large group of patient advocates or just patients there, and really interesting talks. So I just wanted to put in a plug for that.
Thank you. It was my last slide, but I didn't get it there. So I think it is realistic. And when I say I would like a realistic but optimistic change in mentality, this is where we want to go. For a long time, we said it's not worth it to diagnose metastases before they give symptoms. And this is still in the guidelines today because we haven't proved otherwise. However, we know that when we detect metastases when they are very small and very limited in number, we can induce something we call complete remission, meaning that the visible part of the disease is gone. And for those patients where we get the complete remission is where the length of life is bigger. And maybe they end up dying of something else. We all have to die, right, of something. But the goal when we say something is curable is that you die of something else, right? And so for very selected cases, the reason why we go very cautiously, and I particularly am very cautious with the word cure, is because I am afraid that we go back again to the confusion that all breast cancers are the same and forget about the needs of the metastatic. But I think we are getting there into a very small yet group of patients, but that are the exceptional responders. Yeah.
Thank you so much, Fatima.
Thank you.
I'd just like to say thank you.